Well, look, everyone, thank you for making tonight available at such short notice for this special webinar. We are very excited to have Margaret Jennings speaking tonight. Many of you might know Margaret and have completed training with her at some point. She's pretty well known. She is a Melbourne-based microbiologist, having worked in clinical and research bacterial viral immunology laboratories, and has been a lecturer and an educator at tertiary level. She was invited by the RSCGP to contribute to the 5th edition of Infection Prevention and Control Standards, and has been educating practices in all things infection control for many years, and of course has been a voice of authority in respect of COVID-19 and general practice. So Margaret, may I extend a welcome to you and hand over to you now.
Welcome everybody, and thank you. There's nothing like a case in your area or cases to, I think, remind us that we're in the middle of a global pandemic, and I guess just when we thought, oh, we're okay, that's what we thought in Melbourne too, you know, in May. We're okay, we've gotten over that, and then boom. So right now, today, I've been working with one of the PHNs up at Shepparton, because I don't know whether you know, but they've got a number of cases there in an outbreak where a person who came from Melbourne who was infectious revealed where they had been, but not all of where they had been. And so they've actually left a bit of a trail, and sufficient to say there's a 6-hour queue today for swabbing, but it's good that everybody's out. And that's the first thing I want to say. The key to all of this is test, trace and isolate. That's what we're doing. We're entering the end of our lockdown, and I really don't think that we'll have to go back into that again, and neither should you. We're coming off a very different base to Sydney, so don't sort of try and compare the two. We're at the very end of this second phase. I'm not going to call it a wave. Wave is more about influenza, actually. So I'm kind of wanting to rev you up, but also to say to you, this thing is looking for your throat, primarily your throat. Yes, we know it can enter through the conjunctiva, lungs, etc. It's looking for your throat. And we do lots of things in our day-to-day, you know, actions that is going to put it there. So really the first thing to do is to think about you. Now, I'm going to give you some tips on what I do as a health professional. At present, we don't visit anybody's place, as you know, where I'm on a 5K limit, etc., but I go shopping, and I do wear a mask, of course. We have to, that's mandatory. But I actually keep a record in my diary of where I went, when I went, and for how long. I've been doing that for months now. So what I'm saying is there's a whole lot of stuff that we can do that is so valuable. Should I find that I'm positive, I know who it is. Of course, I've been 1.5 meters away from people, but for you guys, it's a little bit different because you've started to get a bit more comfortable, a bit cozier. And today, I guess I'm going to wake you up a bit. All right. So today I'm going to say symptoms. And what we've learned in Victoria is it's as soon as a symptom starts. What we knew at the start was that people were saying, oh, I'll give it a day or so, bit of a scratchy throat, but I'll give it a day, see if it goes away or gets worse. No. So I'm talking about you and the way you run your little story, your narrative. So your story is, I'm in a household with a number of people. I'm actually going to keep an eye on them too. And I'm going to say to my household, my bubble, I'm going to say to them, listen, if any of you wake up or develop something during the day, I'm taking you off for a swab. So that's the way we begin to operate, because as soon as that result comes through, which will be 24 hours, then we can start doing some contact tracing, because I tell you what, with what they've been left up in Shepparton, they've got now 6 days of contact tracing. If the person had, well, in fact, the person was positive and went out of Melbourne. Don't start me. So this is also about human behaviour. But if the person was, you know, isolated as they should have done, as soon as they received the positive, they wouldn't have been wandering around. So if you do your test as soon as you have a symptom, can you see the time that I could have infected people is narrower, narrower, narrower. Plus, you're probably often not going to return a positive swab if you wait 5-6 days to see how you went. So we know that the most infectious is that day before, and for possibly 4 or 5 days later, as long as you're getting better. Of course, if you don't get better, it's likely that you actually remain positive. We know that. And we also know about the people who we call the long haulers, who are still testing positive 3 and 4 months later, and some of them in the younger age group. So how can I set your compass? So I'm going to set your compass for you personally and say, am I keeping a diary? Now, I don't mean keep a diary and go anywhere, but I'm thinking keep a diary, and I'm a healthcare worker and I actually owe it to other people, not just myself. I owe it to the people I care for not to get infected by doing things knowingly. What do they say? You don't know, you can't know what you don't know, but there are things that you may have been doing knowingly. So tonight's a bit of I'm going to go to my diary and I'm going to write out. Sometimes you can work it out from your mobile, etc. Where have I been? Where did I go? Now, this is gold. I know some of you don't have, I don't have the contact tracer app because my silly phone won't do it. But this is gold because then you can read where you were when you match up where the cases were. Keeping an eye on the people in your household. You know that 15-year-old who never comes out of their bedroom? Well, maybe they're sort of not going to get it, I don't know. But you've got a sore throat? I'm taking you for a swab. People who continually say to you, and this happens to me, I'm okay. You don't need to worry about me. I don't go anywhere. Well, you know what? We all do. The virus doesn't move. We move it. And that's a really hard lesson to learn. We are moving it. I might just, duck down to the fish market 40 kilometres away. You've moved it. So the other thing I can tell you about human behaviour is we self-assess personal risk as low. How many of the, was it 14 or 15 positives today, how many of those thought that their swab would turn up positive? I can tell you very few. Oh, it couldn't be me. So that's a real human thing. So today is so much just about the way we operate as human beings. I think you've had the science. You've had the science from me. But this is, oh yeah, or when you get that sore throat, the first thing you say to yourself is, couldn't be me. And then I haven't really got a sore throat and I'll just see how it goes. Well, don't see how it goes for any more than about 20 minutes is my strongest advice. We have a system in Victoria too. If you can't get to a testing station, they'll come to you. So people are going all out. The authorities, the department are going all out to make sure people are tested quick, like get tested immediately. So spread that sort of word to all and sundry. The next thing I want you to imagine is I need to act today as though I am the day before symptoms break. In other words, I'm infectious. How do I conduct my business, my work, and my shopping? How do I conduct that as though today is my pre-symptomatic day, if you like, and tomorrow I'm going to get symptoms? In other words, I can infect half of Sydney, if I really tried. So that's how I get people to think here when they're in the clinic, because all the clinic staff want to say, it's those patients, it's those patients. And I go, oh, sorry, it's as many staff as it is patients. We had a general practice 2 weeks ago here in Melbourne, and I think they're still chasing a few around there. I'm not keen on clinics doing any testing themselves. I really honestly think we've got enough testing stations. I don't need to show you how to put on the full PPE off and on, but what I will show you today are some really safe tips around taking off your face shield and your mask, wiping the face shield, hanging it up to dry, removing the mask, hands, and having a break every 2 hours. So you would be expected as healthcare workers to be wearing mask and face shield during your working day. What I want you to do is to have a break every 2 hours. Now I can just hear what people are saying. but I need you to know what we've learnt. So for a start off, the mask is really not much good. And I'm talking surgical mask. I am not going to teach anybody how to put a P2 mask on tonight, because there is really no call for this in general practice. It's an enclosed space, cohorting of cases. That is not occurring in general practice. But, you know, these are the smarts about, I'm going to act as though I'm pre-symptomatic. So I'm here to protect other people. So the first thing is when I wake up in the morning, how do I feel? Now, if it's a cough, it's really a new cough we're talking about. Fever, well, maybe 45% of people get a fever. So the symptoms, it's a long list. But if today the only thing you did was to take each other's temperature and you found it boring and why do we keep doing this, tomorrow it will be different. Because tomorrow I'm telling you the contactless thermometer is next to useless. Oh, then you say, should I go and get a tympanic? And well, yes, you can, but the symptoms. So, yep, do your contactless. Don't do it near a cold area or you'll be recalibrating it every 5 minutes. But do your temperature, do your contactless, but now let's start on the symptoms. So it's not just a bit of a sore throat. It's not just a cough. It's a list. So some of you are recording tonight, you can watch this again, but let's go from what we know. And, you know, there's probably stuff that we don't know yet. So we know about fever in about 45%, but if people have been taking Panadol, guess what? That's going to lower their temperature. And the elderly, about 35% of them might get a temperature. So just be really careful about how you use that information. So you do that, and then it's the symptoms. Now, honestly, when the patient books, by the way, no walk-ins, when the patient books, and you might even have a sign on your door for your walk-ins, and they simply call you as they approach the door, and you can ask all the symptoms, give them a time, and just say, wait outside. So I'm really concerned about the space that you're doing your admin and reception in, that people aren't sitting there waiting. I'm concerned if your windows don't open, if you don't have doors to exchange air, windows and doors. So we're very big in Melbourne and have been, and it almost snowed last weekend, but windows and doors are open. And you can get a security screen if you haven't got a, if you want to sort of keep it secure. So what we know is that, first of all, being outside, and lots of doctors are seeing patients in cars here. They've bought those little tents from Bunnings, a lot of them, and put a couple of chairs there in the car park. Everybody seems happy. And occasionally the patient's got to go inside to be examined. So that's where we're coming from at present. But going back to the symptoms. So yes, you can do fever. Mind you, some of the patients go, I don't think I've got a fever. And then their partner says, oh, you were burning up last night. So there you go. Not everybody knows they've got a fever. Scratchy throat, doesn't have to be rip-roaring sore, but feels a bit odd. Okay, so scratchy throat can be sore throat. Cough tends to be a dry cough, but a new cough. Okay, and look, there's even a description of how many coughs per hour or how many fits of coughing, but I won't go there. Headaches, shortness of breath. Now, a lot of people don't know that they're a bit hypoxic, etc., etc. I'm okay, they say. They're quite happy and jolly, and you immediately suspect hypoxia or something like that. So really kind of getting a feel there that they, no, I'm not short of breath. What else? Joint and muscle pain, and that can sort of be that bit of interferon production can do that. You know, the body's sort of natural defences kicking in maybe a little bit, and the virus itself. Headaches. Then you can get into the loss of smell and loss of sense of smell and taste, a bit more common in the younger people. Nausea, vomiting, and diarrhea. Diarrhea tends to be after the nausea and diarrhea. I think you can work out what's going on there. And then in some patients, there's been a presentation of rash on the feet. Tends to be associated with neurological symptoms. And I've actually got a dear friend of ours, one of his architects in the business, still off 3 months later and still positive. A fit guy in his mid-40s and presented with those neurological signs. Depressed as all get up. But they don't know whether that's one of the neurological spin-offs or whether it's, you know, because of he's depressed, he's not at work. So, you know, these are the effects. It's not, you know, people talk about it's just an old person's disease, which offends me, because I'm getting into that zone. But, you know, it's affecting different people, different ways. And as I said, you can get the long haulers. So thinking about yourself, you don't want to get it, but more than anything, you don't want to pass it on. Okay, we don't want to be one of the 20% who end up in a bit of strife. So you know that a lot of people won't, but it's who we all associate with. And so when you hear people say, oh, I don't see anybody, that's not actually the case in Sydney. But even here, people cheat a bit, and certainly we found somebody not doing the right thing last week and taking it away from Chadstone. So for you, think about yourself, think about, yeah, what questions am I asking the patient? So I'm really happy if you extend that to you. Not just I'll wave you through, oh, you're okay, aren't you? No, let's go through those symptoms. This is the stuff that costs nothing. It's low-hanging fruit, and boy, is it value-adding. So I'm not asking anybody to spend money. The next thing is, why have I got a waiting room? Honestly, you want to reduce risk, don't have a waiting room. That's my advice. Strongest advice. You can't open the windows. Just a little assumption, patients are wearing a mask, correct, when they come in. If not, they put one on. Okay, so that they keep risk low for you guys. You've got your mask on, you've got your face shield, but we know that when both parties have it, we can get up to about 80% protection, maybe 40% if one person's got it on, 40 to 50. So it can be up to 80, 85%. I think it's worth protecting each other because you might be the one who's infectious, okay? So we want our patients to wear a mask. Lots of people have homemade masks. It's okay if the patient brings a homemade mask, that's fine. Of course, they touch it, don't they? Then they wear it under their chin. We all know about that, but we don't do that, do we? Because we know that we'll self-contaminate. And I can tell you that it's 35 to 40% of the time that healthcare workers use PPE, they self-contaminate. Now, I look with amusement at everybody, doctors, nurses, everybody, going on and on and on about the levels of infection. And I don't want to point any fingers at anybody, but when I see a gown with the cuff underneath, I know that that person has not been trained or does not put their PPE on properly. If ever you have to wear a gown, I actually don't want you in the position of wearing a gown because you're going to send those who need to be swabbed or symptomatic.
Hi, Mark.
Yes?
Mark, we're getting some questions coming through.
Good.
So,
Good.
okay, to sum up Naomi's question is doing the triage, the question correctly, and patients say, no, all fine, all fine. They're turning up for their appointment and they've got a cough, but they're already in the waiting room. What can reception staff or GPs do to somebody who has turned up with respiratory symptoms?
Always assume. In other words, the questions we ask, you know, 9 out of 10 people will answer correctly. Some people don't care. Some people don't believe it exists. Remember that. But here is a suite of things. So just imagine the person didn't declare because they thought, you've got to think about the way patients think. If I tell the nurse or the receptionist that I've got a, they won't let me in. See, so you've really got to get into patients' psyche. So I would say to patients while I'm asking the symptoms, look, just tell us. We certainly never turn you away. We just do it a bit differently. That's what I would advise. You know, and you might see them outside, but I tell you what, they're not coming in without a mask. So I've got to protect you. So let's say the patient didn't divulge, but guess what? I'm not using a waiting room. They're not sitting in the waiting room, so they don't spend any time there. The only time they come in is to see the doctor and go out. And if the doctor can see them outside, even better. The next thing, they've got a mask on. So can you see, and I've got windows open, can you see that the more things I do, the more levers I pull, the lower the risk. So even if, we know this, even if the patient doesn't declare symptoms because they really want to see the doctor and not tell you at reception, even if they haven't declared it, if they haven't waited in the waiting room, if they have a mask on and you've got ventilation and they get to the doctor and the doctor's room's got ventilation and they then say to the doctor, I've got a sore throat, but I didn't want to tell the nurse or the receptionist, the risk is quite low, okay? So I can't tell you how important the masks are. They have saved our bacon here, I think. And I don't think we need to give people a lesson on mask wearing, our patients. But can you see, if you're not doing anything, you're definitely exposing yourselves to risk. And you're then saying, oh, well, more or less I'll leave it to chance. But I don't think that's a really good way to operate. So hopefully I'm giving, so you may not be able to open windows, you may not have any windows. Oh, don't put the ceiling fan on, because that actually propel the droplets out even further. But if the patient's got a mask on, reduced risk. So think of all those things. You've asked, most patients are pretty good, I have to say. Most are pretty good. But you've got to give them some assurance. Got to give them some assurance that they're still going to be seen. Go for it.
Can you confirm the changing of masks and having a break to change your mask and clean your shield every 2 hours, did you say?
Yes, and I'll tell you why. Because as soon as your mask gets damp or wet, not effective. So it just happens that works out. Have a break. Hydrate. Certainly no drink bottles at work or mobile phones while you're actually actively working. So keep those in, you know, in the car or tea room, or don't even use the tea room, quite frankly, but I don't want to be too cruel first up. But I think you can see the tea room is an enclosed space. Oh, hopefully you guys can go outside out the back and have a nice little seat and some palm trees and bits and pieces. But the more we do outside, even if you've got to be inside for those 2 hours, to be able to get that break is so good mentally. And of course you take your mask off, you're outside, and you're drinking. So there's no expectation. We do wear our masks outside here in Melbourne, different situation, but we certainly take them off to drink and eat when we're outside at the park and stuff like that. So thinking about all of the levers, can I use all the levers? No, but I can use some of them. But I would be a little bit shocked if after tonight people go, oh, I'm not going to ask all those questions. Oh, no, we can't get a mask on everybody. I'd say, well, then you are really exposing yourselves and your other patients as well as your staff to high risk. So think about it. It's going to be so different for every practice. One practice will go tick, tick, tick. Another practice will say, oh, we can only really do the mask and the questions. That's pretty good. But to not have the waiting room is gold, because you know how long some of the patients end up in the waiting room. Then they want to go to the toilet. So the cleaners tell me that it's a joy cleaning practices at present, because there's no waiting room muck, there's no toilet muck. They're quite all right, so I shouldn't sort of say that. But so that thing with masks is, I think while some of the standards talk about you can possibly wear them a bit longer, I tell you, no heroics. I'm telling you, they're wet, really, by 4 hours. So at 2 hours, they're damp. But use that as your opportunity, even if it's 10 minutes, honestly, because people are really sort of on their knees right now in Melbourne. And so I'm saying to them, just get yourself into that headspace of every 2 hours. And I tell you what, come back a little bit more refreshed. Lots of the staff are going out to their car where you don't have to wear a mask. You'll be on your own, sorry. But no mask, turn the music up, got the thermos, got the noodles, happy as. And for their afternoon break, a lot of people just walk up and down the street for a few minutes.
Mark,
so, yeah, go for it.
Sorry, can just a bit more information on the problem with staff having drink bottles or using their mobile phones at reception, or GPs having their mobile phones on their desks?
Well, think about this bug is looking for your throat. It's looking for your throat. And if you have a drink bottle on your desk, okay, it's going to find your throat, because you'll touch the drink bottle, pull the top off, go like that. And it's just sitting there for people to breathe and cough over as well, you know, even other staff. So no, please no drinking. With your mobile, I'm talking about your personal mobile. So if the doctor's using their mobile for actual work and they're in their consulting room, then, and they might see a lot of the doctors here, well, I shouldn't say a lot, but quite a few doctors have actually now said that they're using their consulting room only for telehealth, and they've even got a One of them said they've even got a coffee machine. They're not seeing any patients in their room, some of them, and they've actually converted the treatment room, which has a back entrance to outside, so the door's open. They're seeing the patient in there. They've got a divider screen with the curtains, and they're going in to see the patient. So can you see how people are reducing the time they're spending face-to-face? So they're sometimes speaking to the patient on telehealth and saying, I think you need to come in. So the patient comes in and they might see them in the car even and say, look, I can, whatever, you don't need to come inside. So for some patients, it's actually a 3-stage visit, but to reduce that close face-to-face contact is critical. And again, everybody assesses risk as low, but I tell you what, you'll be thanking your lucky stars the day you're told you did have a positive at the clinic yesterday and you worked through some of those, some of these, you know, suggestions, advice, tips that I'm giving you, because the only thing you've got to do is reduce time contact. And certainly you and the patient have got a mask on, but you step back well beyond the 1.5 metres when you finished examining them. Do not trust the 1.5 metres when you are in an enclosed space, because the small droplets, don't call them aerosols please, but the small droplets remain suspended. They've got a bit more virus on them than the aerosols. This is not particularly an aerosol, you know, we're not doing any aerosol generating procedures, no high flow oxygen, no nebulizer. So the small droplets dry off a bit but remain suspended in an enclosed space. This can be a risk. This is what you want to avoid.
Okay, so there's some questions that are pretty general about providing masks for patients. A lot of practices put the sign or put a note on their website, or when patients ring up to advise patients they must wear a mask. This is common practice throughout New South Wales, Victoria, and pretty much all states. Patients know to bring their own mask. If you've got someone who turns up without one and you have done triage and you're willing to have them in, by all means, for your safety and theirs, please give them a mask. If a patient has got,
it would be, a condition of entry is a mask.
Absolutely.
Unless it's a child, you know, or somebody who can't. But symptoms, I mean, I say to my clinics, tell the patient who's booked to reassess their symptoms an hour before they come in. And if they have any symptoms, to let you know, and so that there can be an alternative arrangement made to see them. In other words, you're not putting them off, but you're saying, you just check yourself an hour before you come in. Here are the symptoms to go through. As I said, this is the stuff that costs nothing. And it can be gold, because I think one of you quoted me $6,500 to do a terminal clean on a practice who had a positive case. Well, everybody, you'll be happy to know that I'm writing a protocol, and it will be on my website by tomorrow night, and it will be how to do your own. I can step you through it by Zoom. It won't be $6,500, it might be $440, but I think you can do it for about $5 of product or $20 of product, and me on the end of the line. So I'm not being cavalier about this, but there are so many balls in the air, so many levers to operate, but symptoms, mask, distancing and being outside, that's what you're going to hang your hat on, because the department will, go for it.
Sorry. Still going backwards to masks, but what do you say about staff and GPs wearing the homemade masks?
No, you've got to have the 3-layer mask. Your homemade mask doesn't cut it, because it will get wet. It hasn't got a really good waterproof layer in there. Think of your mask. I'm going to show you something. Maybe I'll do this like
if a patient wears a homemade cloth mask, that's okay.
Yeah. Because you see, you've still got to multiply up the 2 protectives, give a bigger protection. You know what I'm saying? Like if only the staff wear it, it's 40%. If the patient only wears one and not the staff, and it's a homemade one, where you might get like 20%, but when everybody wears them, it goes up. So look, I've actually, committed a crime here and cut a mask up. I just want to show you the 3 layers. That's what you want. So polypropylene, this is more or less your little waterproof layer. Here's your polypropylene that the droplets, will sit on, sort of thing, if they get in. And here's the bit of that I wear against my face. So you don't twist these. I see lots of people twisting. If you've got a very small face, maybe, but if you actually want a gap here, because that's where the air is coming from. This is like your personal sneeze shield. So you actually need to make sure about halfway down the nose, make sure you, okay, pressed it there. So I'm actually breathing through this, okay? So none of that. If the patient comes in like that, just say, would you mind covering your nose? What about this? Well, then they've already self-contaminated themselves. Or if you're very creative and you need a cup of tea, that's probably the least. But really for us, as soon as we take our mask off, in the bin, have your cup of tea, go to the toilet, whatever, come back, a new mask on and your face shield. Tell me when you want me to take you through the face shield mask routine. Will we do that now?
Yeah, Matt, we're on masks. Let's talk about it.
Let's do it. So the mask is for droplet spread. Now, don't get too excited about hearing, don't get aerosols mixed up with aerosolization procedures, all right? We're not doing anything heroic like that in general practice. But what we are aware of, and actually we haven't got strong proof of the intervention, but you would have heard heaps about them saying, oh, I haven't got I need a P2 mask. Well, no, you don't. Not for 95% of things. And in general practice, honestly, I wouldn't use them in general practice because it's only certain situations where you need to use them. But I can tell you, the more PPE that people wear, you can guarantee they'll stuff up even more. So why don't we use what we've got really well? Okay, so we're not going to give the patient a hard time if they've got a homemade mask, but we're going to give them one of ours, our surgical, if they don't. If they're refusing to wear a mask, I'm sorry, they're not coming in unless they've got a really strong, you might even have a spare face shield, for heaven's sakes. What about saying to the patient, is there a reason why, perhaps there's a reason why you can't wear the mask, but it's to protect everybody. But what the patient's doing is saying, oh, I couldn't have it. You see, they're doing what we do. I couldn't have it. So self-assessing as low. This is the precautionary principle, and then there's the prevention paradox. I don't see it, it isn't here. Well, as soon as you've got a few cases, in Sydney, everybody rushes out and has testing. But you would have seen the last few months, people would have, I can't see it. It doesn't exist. Got to be really careful. Okay, so to put it on, always do hands. Okay, always do your hands. And remember what I said about jewelry and long nails, and rub for about 20 seconds. Okay, it's really got to be that wet. Otherwise, you're not really knocking off anything. So once you've got it on, your mask goes on like this, and really pull it down so you've got a really good shield there. They say that you know that you've got your mask on correctly when your eyes don't fog up. Now, here's a face shield. Now, look, this is not labelled disposable, nor did it give me any cleaning instructions. So I go to the website, and I've got instructions for you as well. And so I am going to clean it. Now, what's the point of this? Well, we do know that it can stop the virus entering through the eyes. And so you say, well, why can't we use these? Patients actually can see you a bit better with this, but also the beauty of this is it stops you touching your mask. Okay, it's got to come below the chin, which this one does. And we think it actually may even make the mask a bit more effective, but don't kid yourself, because the virus can, if you didn't wear the mask and you only wore this, the virus can come around. So we like these, everybody wears them. Now, you've done some work with the patient, and 2 hours is up. And by the way, you can keep wearing this for patient after patient as long as none of them are symptomatic. You're going to have to change after a symptomatic patient, but you've seen your patients for 2 hours, etc., in a treatment room or a converted waiting room or whatever. or you want to do it in your consulting room, but really the doctors do like to do their telehealth and lots of meetings, Zooms and everything, so a lot of them aren't seeing patients in their own consulting room. They're very happy about that. So it's come time for me to have a break. So this is what I'm going to do. I'm going to take off, I've done my hands, but I'm going to take it off only by touching the back, and I'm going to grab my detergent wipe. Okay, I don't particularly have my gloves on, and I'm going to clean the side that was against my face, and I'll get another one. I'm a bit of a fan of just using a clean one for every surface. I might even, not that you can clean foam, don't kid yourself, but at least I've patted some up there, and now I'm coming across the front. Okay, nice and wet, cleaned it. Now I grab my disinfectant wipe. So some of you will have wipes that are both disinfectant and detergent. So yes, you're going to be going through a few of these, sorry. So I now disinfect, and the secret with disinfection is you always clean first and you leave it really wet. Grab another one. Don't try and disinfect the sponge, I think that's impossible. So, all right, really wet, hang it up on the back of your door or something like that to dry. At the end of the day, wash it. Actually wash it and hang it up to dry. If you're not going to wash it, and I do want you to wash it, you can use something like a snap lock, you know, the large snap lock bags, maybe for the weekend or something like that, can go in there. Now that's that bit. I now do my hands again, and I can take off, down and away into the bin. Go and have my tea break, my toilet break, and of course I'll be washing my hands after the toilet, etc., etc. So I'm not asking people to be wearing gowns all day. A lot of you wear scrubs. The doctors love their scrubs. That's great. I would change my scrubs before I went home, pop them into a bag, change into my civvy. Some of the doctors wash these scrubs and just leave them hanging drip dry. You know, they've usually got about 2 sets. It's not essential. It's not essential. Shoes and clothes are not really where this is being transmitted. It's being close up, unprotected. This is why our family bubble is a risk. Okay.
Now that you've talked about cleaning, the cleaning questions are coming in. How about cleaning BP cuffs, stethoscopes, and then anything strong, clinically strong to get rid of COVID? And what about wearing gloves in a consult?
No, or hang your hat on your hand hygiene. The only time you need to wear gloves is when you're actually performing contact precautions. And if you've got no reason to believe that if this person is not symptomatic, and we don't go chasing shadows, believe you me, but the problem with people just putting one pair of gloves on and wandering around the place is that they will not do hand hygiene, because every time they touch something that's in, they don't do their hands. Oh, I've got my gloves on, and we'll all know where that goes. So the only time you put your gloves on, obviously touching, you know, anticipating contact with body fluids, mucous membranes, surgery, etc., and contact precautions where there's a known. You know, so if you're examining somebody who's got gastro, somebody who's got flu, all that kind of thing, yep, you put all your clobber on. But for that ordinary examination where I'm, you know, palpating or something like that, then it's it's hand hygiene, and it's before and after, not just in between. We're really finding out, I think, with this that we're a bit slack, I think, before. So you can't get enough alcohol in this life. I mean this sort, okay? I don't mean the drinking type. I think we've all gone a bit, I think we're swearing more in Victoria and drinking more. This is really bad. But anyway, so don't be like us, all right? Cleaning, you want to know about cleaning? Oh,
yes, especially BP cuffs.
Okay, so we know that you really can't, well, you can sort of wipe, but you really can't disinfect a blood pressure cuff. So you see in the hospital, they will have I think they have some sort of a wrap or something that's disposable, but they often tend to have it, stays with the patient, and then it goes off and gets some sort of treatment. Don't ask me why, I don't know. I'm not into lamps or fogging, certainly no fogging. But what I want people to think about is, you know what? I've never been wiping the equipment between uses, so I think I better start doing that. So the stethoscope, just automatically wipe it between patients. The little oximeter, wipe it between patients. I'm reasonably okay about it being a detergent wipe, but if you want to use a, detergent disinfectant, just drop them all. If you want to use a detergent disinfectant, as long as it stays wet. And also, how about we put stuff away? So can I talk about clutter?
Can you,
All right.
just before that, back on the BP, can you put a paper towel in between the patient and arm and the cuff instead of cleaning it in between?
Always go to manufacturer's recommendations, but I wouldn't get distraught about it because the blood pressure cuff is not going to be as critical as something that is, I was going to say, if the doctor's infectious or the patient's infectious, it's got to get back to their mouth. So remember, everybody will be doing their hands, okay, after they've done that. So the doctors will be doing their hands, the patient will be doing their hands as they leave the doctors. And so really there won't be much scope for anything to come off the blood pressure cuff. You'd really sort of have to be contaminating it as well. Don't worry about a few bits of virus. We think we need somewhere between about 300 and 1,000 particles to get crook. But you can't wash a blood pressure cuff. You can wipe it. You can attempt to wipe it over, but you must accept that the instant you put a bit of disinfectant, like quaternary ammonium, your ViraClean or your wipes, as soon as don't use alcohol, please. Alcohol is really affected by organic matter and it'll just do nothing. Plus it's got to stay wet for about 20 seconds and that only happens on our hands. So I also steer people away from bleach. That's just me. And I would use, and I haven't got shares in the company, but I would just hang my hat on some ViraClean as well as my wipes, okay, as well as my detergent wipes. So I wouldn't be using alcohol at all except for hand rub. But going back to your question about the blood pressure cuff, so I would say I'm going to have a fairly clear bench. Anything that should be away is away, because I tell you what, the day you have a positive case and this person is suspect in front of you, and you do your clean, you're going to have to throw out, most likely, a lot of stuff that's in open boxes and all that kind of thing. So I tell you what, if you've got a Marie Kondo in your practice, get them busy over the next day or two. And people are saying to me, some of the things about this pandemic, they've actually reassessed how they're conducting their practice. Now, I think that's really interesting. They're having more breaks. That's pretty good. They're having scrubs, which they like, not essential, but people are looking at this, and also their waiting times and the waiting area. So there are some good things coming. So for cleaning, we just use a detergent and paper towel. Sure, you can use a cloth if you've got access to a laundry, but who has? Nobody has. And I don't want those things going home, please. So some people buy those rolls, it's like chucks. They're on a towel roll, the disposable towel. Some people use that, and other people use paper towel. So if it's your regular clean, I'll divide the clean up into an ordinary clean, an ordinary COVID normal clean, and oh no, we had a case an hour ago, one of those cleans, the big ones that you're asked to pay $6,500 for. So let's do the simple one. What is it that I need to be doing each day or even twice a day? So this is how you think. The place is going to be cleaned each day as per normal. So that means, the floor gets done, this, that, t'other, all right? The ordinary normal things. But twice a day, and I like the staff to do this themselves, we do what we call our high touch surface cleaning. So that means I get my gloves on, you automatically got your face shield on anyway, and I know the list of things. Now, people can do their own high touch surfaces, but eventually there are common areas that need to be done. So whether you want to designate somebody in the morning, late morning after a few people have touched things, and again late afternoon. And then the cleaner can do them all again at night time. But essentially, your high touch clean is wiping each surface with a clean piece of paper towel or wipe. Look, you can cheat a little bit, I'm sure, and turn the wipe over a couple of times to get a few doorknobs or switches out of it, but not just going like that all over the place with one cloth. I think you can see what the point is that I don't want to transfer. So what you do is you actually start from the least high touch surface, if you can imagine what that is. So you might say, oh, the light switches don't tend to get touched very often, or I don't know, what's the most touched? Oh, the Medicare machine, but you probably do that after every patient. You guys shouldn't be touching that machine. That can be put on the table in front of your sneeze shield, and you really don't touch it. We don't have any of that sort of touching in Victoria, but I did speak to a clinic today up in Shepparton, and yep, they're turning it around and giving it to the patient, and next thing they'll be taking cash, and next thing they'll be giving receipts. Don't go there. So if you've got the patient, yep.
Sorry, you just mentioned the sneeze shield, and there is a question here asking thoughts on the shields. Are they effective?
Yes, yeah, everybody should. Doesn't everybody have one? Okay, so you have a sneeze shield installed, and you also still wear your mask at reception and eye protection. And remember, it's reducing, because as I said, the day that you do get a positive, look at all the measures you've taken to reduce your risk. I tell you what, I'd rather be on that side. And also your cleaning. So I've just mentioned what you would do on a day-to-day basis with cleaning your high-touch surfaces. You've cleaned them with detergent, the high touchies, and now you're going to go over them with your disinfectant, one that's not bleach, that doesn't ruin your carpets, and not alcohol, which ruins all the rubbers and vinyls, but something like a quaternary ammonium compound, like ViraClean. And you go over, it's neat, no sprays. No sprays, we don't do any sprays. Sorry.
And what about hospital grade disinfectant somebody's asked about?
Oh, yeah, but quaternary ammonium compound. So you're looking for a benzalkonium chloride. That's what's in ViraClean.
ViraClean, everyone.
Cheap as chips. But go down to the cleaner's cupboard and see if you can find benzalkonium chloride, 0.4%. 0.4%. So you don't have to actually, with the ViraClean, you can actually dilute 1 in 10 in warm water and wash with that, clean with that, and then you can have it neat, pour onto your paper towel and disinfect straight. The key with disinfection is the surface must have been cleaned first. You can't clean and disinfect really a surface that's touched and got muck on it. Then when you disinfect, you leave it wet. It's got to be wet for the number of minutes that the manufacturer says. It's usually somewhere between 1 and 5, okay? So really, really wet. That's what does it.
I'll just ask 2 more. Wearing your own glasses, yes, they should be cleaned, not just at the end of the day when you get home, at the same time as when you're changing your mask, Marg, or when you touch?
Look, I reckon people would forget to, I would forget to do my glasses for sure, but if you never take your glasses off, don't panic.
Touch them.
Just think about, am I doing enough hand hygiene to cater for those times when I might have touched the face? I mean, you've got your mask on, your glasses, but I think some of us wear our glasses fog up with masks. But how about really perfecting that skill of putting your glasses just sitting over there on your mask so that they don't fog up? I think it's a skill. I really feel for those of you who are doing this, but try and get that break after 2 hours, but because you'll just start to touch everything. And I think that's a real problem. So thinking about that, so some of these things you might not have thought about till this week, because you might have thought that we were all a bit crackers, you know, down here, just like we thought other states were crackers, you know, 4 months ago, and now it's us, and it'll be somebody else next time. I mean, look at all the positives who are coming in by plane. I can't believe there won't be a leak out of there, but I shouldn't sort of say that. So going back to the clean, it's detergent and paper towel or one of those disposable cloths. Avoid sprays just for splashback, inhalation, the fact that you can't actually dry a spray mechanism out. If you've got to make something up each day from it in a spray, you'll just be contaminating. Contamination will just build up. So just what we call a pour bottle, or otherwise, if you want to do your twice daily high touch clean with your wipes, just go clean with your wipe and disinfect with the disinfectant wipe. That's, excuse me, that would be my recommendation. You will be going through a lot of wipes, and that's why a lot of people do like the paper towel. But other people do a bit of a mix and match. They'll do the paper towel and detergent for some surfaces, and always give the doctors wipes, so that, and the nurses wipes and the receptionist wipes, so that things can be wiped down as they go. So some people really are clean freaks, and but you need a clean freak, you need a Marie Kondo, and probably a nurse ratchet. That's who you probably need in your clinic to sort of sort everybody out. Sorry, I shouldn't be laughing. I should be like so serious and devastated, but it's what happens after 4 months, everybody. We're all going a bit spare, but just focus on the stuff that doesn't cost anything, and just that extra bit of time, and you'll just thank your lucky stars. If you've got to do a deep clean, which I'll describe in a seckie, if you've got to do a deep clean, it'll be so much easier. If you've not had the patient in there very long, if you've kept everything away, if you've wiped everything after you've used it on that particular patient. So you get a knock on the door or a call from the health department, or you find out somehow, this morning you had somebody in there and they turn out to be positive. And you go, what do? Do you run around and clean everything? I wouldn't. I would actually leave, put the phone on with the appropriate message, a sign on the door, do my hands. I would actually change my mask and face shield the instant I hear about this, within reason. Like if it's occurred this morning or in the last hour or two, I would actually change everything, thinking that the patient has come through, has been in, and to reduce my risk, I'd actually take all that off in an area where the patient hasn't been, put a fresh mask and put my cleaned face shield back on, obviously doing loads of hand hygiene. And I would say, okay, the patient came through, so they did not stay in the waiting room. They were in the doctor's room for 10 minutes. Well, there's a problem. And then they came back and they paid. So they did stop for a minute or two. But imagine if they've waited for half an hour in the waiting room. Imagine they haven't had a mask on. The contact tracing is enormous. So you want to put yourself in a position of minimising the fallout, and you want to open tomorrow. So I would have my PPE, my bags, my hand rub, everything ready. I'd put it at the door, and then I would just lock. I'd make all the windows open, doors, security screen if you can, and I would just disappear after I'd let everybody know. So everybody leaves. I would not be cleaning as soon as the patient leaves. If the doctor came out and said this is a suspect patient, that's almost the most infectious or the worst time. I would really wait a few hours. If you're desperate and it occurred at 9 o'clock in the morning, you could maybe come back that night, but I'd be a lot more comfortable with at least 4 or 5 hours elapsing. I like 24 because it also gives time for the virus to become inactivated on more the papery, fibrous surfaces. We know that it really doesn't remain infective that long on there, but on the more shiny surfaces, apart from copper, copper's really great. Get a copper bench in, it'll knock the bugs off very quickly. But on the more, the glass, plastic, stainless steel, those surfaces, it can remain infective for a bit longer. So I know that after 24 hours, it's also dropped off infectivity on those surfaces. It doesn't remain the same. It starts to drop off quite quickly. And so I come back in the morning early because I want to open up at 9, 9:30. And so I might come in at 7, but with a mate, with a colleague. And we put our PPE on. I'm comfortable with an apron. The point of the gown is more to protect your clothes. So an apron is fine. And I've got my gloves on and I've got all my stuff on, okay? And I've got hand rub there. And so both of us set to our task. So one person will be wiping over the broad surfaces, the benches, don't forget under the bench where people touch, etc. One person's doing those, and you pick the rooms where the patient has been, okay? So they've come through reception, etc. They've gone through the doctor's room, or they've gone to the treatment room. But think about the clutter in those rooms, because you have got a mammoth task if that's all got to be done. Otherwise, you close the clinic for a week and let the virus become inactive. I think I'd be wanting to open up tomorrow. That'd be me. So put yourselves in a really good position of low risk and being able to do that deeper clean yourself. And so, yep, it does involve high to low and clean to dirty. So that person who's literally my general cleaning person who's coming in with me, I'll do the high touch surfaces, which will include a disinfect, but they're going to be doing shelves and whatever in that particular room or those rooms. So top to bottom and from the cleanest to the dirtiest. So they've got their gloves on. So you have the one pair of gloves and you're going clean to dirty, top to bottom. Okay. And including the floors. And I wouldn't get excited about bleach on the floor, honestly. I think we can back off. So I'm happy with the detergent. If they want to use a detergent disinfectant mix, one it's called a detergent disinfectant mix, I'm fine with that as a one step. I really just, I wouldn't be panicking. But anything that's touched, I will be cleaning and disinfecting for sure. Okay, so I then say to myself, I'm the one doing the high touch. So which are the less touched, high touch if you like, and I work through. So I do the clean, really good clean, pressure on those handles, pressure on those switches, pressure on those keypads, really good pressure, separate wipe or paper towel each time, going from cleanest to dirtiest. Okay, let's hope they haven't used the toilet. All right. And then I'm going to get my disinfectant out and I'm going to repeat in the same order. And remember, I'm going to leave them nice and wet. Okay, then it's time for me to go to the door with all my bins. My bags are full of paper towel or cloth or whatever. Some people like to actually throw everything out, their bags of wipes and all that. Some people have said to me they actually prefer to do the floor with wipes. They're very happy to just crouch a bit and do the floor. That's fine. Issues around carpet, I would not be getting vacuum cleaning right then because I've got droplets, that can just dry and just go through the vacuum cleaner at the back. I'd be a bit more keen on arranging a steam clean, and I don't think it has to be done that instant. And remember, the floor is not a huge source of infection. So you would say, I'm going to arrange a steam clean, they can't come till tomorrow, or the next day. Don't panic about that. High touch surfaces, absolutely, but leave them nice and wet. All right, leave them to dry. Some of them will say a minute, that they've got to be wet. Others will say 5. So it might even be that you've got to reapply it if it dries in 2 minutes. Is that the most important thing you can do? It's really the range of things you do. But if your windows are open for those 24 hours, that is really going to help. And if nobody has been in that room for those 24 hours, that will reduce risk to them. So, and your correct use of PPE. So you come to the door with your bags of goodies and everything, you and your colleague, and you've got to now think about where is the clinical waste bin, because everything is now going to go into clinical waste. So the only time we put masks and PPE into clinical waste is when we have had a suspect or a known case. So some of you are ending up doing a clean because the person is a suspect case. So whereas others, if they're faced with a $6,500 bill, they'll go, no, I'll wait till they're confirmed. And really, I'd be doing a clean like that on the suspect. And quite frankly, the only colds going around Melbourne right now are COVID. So nobody's got colds or gastro or anything here at present because they've been doing the right thing largely. Okay, so hopefully that's given you a bit of a flavour, but think of the stuff that doesn't cost anything and just be COVID smart, I think, because this is going to be for a year or more. I can't see a vaccine getting around to all of us in the next year, but anyway, you never know. And it'll just have to sort of work its way out one way, but I really want you to try and snuff it out for sure. Okay, so there's a little bit. Any more questions? Any more questions?
Sorry, Marg, I was talking with myself on mute. So Dr. Moore has probably answered this question already. It was just giving people an idea of what happens if there is a case that goes through the practice that you might find out from the patient yourself or from the staff member yourself, or the public health unit might notify you that you've had a case go through your practice. Okay, it will be the Sydney Local Health District, and you'll be notified, and they will advise you what to do, and they will do the contact tracing and talk to all the people involved. So yeah, it's liaise with the public health unit.
Absolutely. And as I said, I want to make your job low risk, because that cleaning is not the most important thing that you can do that day. It is, phew, we all wore our masks, the patient wore their mask, they didn't use the treatment, you know, they didn't use the waiting room, the windows were open, and you know what? If that case, if you've had a positive case and you've done all those things, you may not even be registered as a close contact, because close contact has got to be 15 minutes face to face or 2 hours, and it's cumulative over a week, by the way. So if you see 3 patients for 5 minutes each and they're all positive and they didn't wear masks, bingo, there's your exposure time. Or 2 hours, same room, cumulative over a week. So they're, you know, they're on the website. So put yourselves in a position that you will get a positive at some point, but what had we done so that we are minimally disrupted? Because our thing is to provide healthcare to our patients, and we're doing it as is required during a pandemic using alternative means. So your means might be some telehealth, but it might be no waiting room. So it's not as though you're depriving people. We're not depriving people. We're trying to make it safe for all of us. And that might be the thing that you engage the person, that look, it is a requirement, but it's to protect everybody. Because you know what? The person who comes in next is a transplant. The person who comes in after that is on high-dose corticosteroids. The person after that is. So I think engaging community, and I think there's been a really strong community feel in Melbourne for sure.
Marg, what are your recommendations for GPs that do home visits and nursing home visits while working in a hotspot? What recommendations do you have?
Okay, so again, telehealth. Most of the aged care consulting is telehealth here in Melbourne. It's just automatic. Now, they might return to visiting soon, but that's the way it is at present. And I mean, good clinical observations by the staff at the home are critical. But honestly, doctors, I love yous all, but I'll tell you what, and I have some really fabulous times with the GPs, but they all agree that their PPE and their infection control is a little bit rubbish, which is nice. I think we could all say that. But you know what? Who's really had to work in that space before? You know, so I think actually that's very disclosing of them to say, Margaret, I think I'm a bit rubbish with my infection control. It's all right for me, 45 years of microbiology, you know, I've learnt something and I'm finally useful, but you can't spend a whole lifetime, you know, like it's not proportionate. To do what we're doing now would not have been proportionate even 2 weeks ago. Okay, and it may be that we relax a bit more with our waiting rooms in a few months, because I think everybody's a bit hypervigilant. So just be aware of that too. Is what I'm doing proportional to risk? Well, I'm in a hotspot. I really maybe shouldn't go to that nursing home. Let's chat to them and see if we can do some more telehealth. Just sort of, you know, a few antenna should be out. But certainly anybody with any symptoms, I think that's the best thing we can say to our patients. Every time you see a patient, give them the rundown on any symptom, your family or friends, you know, tested straight away, don't wait. And that's really helped us enormously, because our contact tracing, I can't tell you, but we've gone from pen and pencil. Not that there was anything wrong with paper and pencil, it's just that nobody else was doing it. So what's happened here in about 3 months flat is they've moved to a system that talks to all the other states, but also we've moved out into local health units. It's happened like that. Anybody who said this should take 5 years, it's almost happened in 3 months here. And I have to say, it's been a class outfit. So the contact tracing, I think within 24 hours, it's something like 98% have been tested and contact traced. So those people are onto it. There's going to be 600 contacts from the 4 cases at Shepparton yesterday. 600. So a huge amount of work, but you want to help these people, and it's a different sort of health. Public health is completely different to the health that you know, GPs do each day. It is a bit more mathematical, I think, but it's also around people's behaviour. So what we know is that about 90% of people are pretty good. Epidemiology, you know, all that sort of public health works on the fact that, you know, 10% of people are, I shouldn't say complete idiots, but 10% of people are just not engaged. So they've had to lock a few people up here.
So, Marg, one thing I've noticed is that wearing a face shield and a mask is very normal practice in Victoria. It's sort of not been a high uptake here in New South Wales with GPs wearing a face shield and a mask. Now we've got high risk areas. What can you recommend?
Well, I think if you go to the national standards, I think it says in all healthcare mask and face shield, doesn't it? Am I on a different planet? But no, I actually thought it said in the in the national one. But you see, what happens is it can say what it likes, but it's, oh, we haven't got any of that around here. Why should I wear all that? Well, that's how we all were, and that's how you might have been last week. So I'm happy if tonight is just that, ooh, I need to get re-engaged. Don't panic, but I need to get re-engaged. And I do need a Marie Kondo in my clinic, and I do need a nurse ratchet, and I do need an obsessive compulsive cleaning person. And have a bit of a laugh about it too, because I'll tell you what, if you don't have a bit of a giggle about some of this and about some of the things you hear people say, I mean, you know, they're probably been posted a million times, but I don't think we can go into spaces where people say, oh, they don't do that there. Well, you know, we can take advice here in Victoria, but we are literally the first city in the world to be coming out of phase 2, or wave 2, if you like. There's nobody else come out of it. Now, maybe some won't even go into it, and that's fantastic. But we are in the middle of a global pandemic, and you've got to keep saying that to yourself, because otherwise you're in Queensland, oh, no cases, everything's fine, everything's normal, until. So I just don't do bragging, because, you know, my family in WA, and I think to myself, if they get cases there, they won't even be able to handle it. So yeah. I think it's a skill. It's a skill. A lot of the doctors are really, I should actually say the flip side of the doctors is they're also actually really used to it, that sort of discipline. And we just need to all re-engage. But it's so easy to say, oh, you'll be okay, little old lady 85. Well, I'm sorry, I don't want to give it to her, let alone, you know, pass it on to somebody else. So, yeah, can't tell you hand hygiene, hand hygiene, hand hygiene. But above that, those things that just don't cost anything. Little bit of a plug for hand care. Hand Hygiene Australia say you are not engaged with hand hygiene if you're not looking after your skin. So $10.50 for 500 mils. That's an Avogard 3M. I'm sure there's plenty of that sitting on the shelves at the warehouse. Put it on before you start work. It's a barrier cream, and it'll just reduce the loss of oil and moisture. I haven't worn jewellery since January the 30th. Short nails, intact skin, that's the way to be. Anybody who thinks they can still paint their nails or have fake nails and tells me that they're doing great hand hygiene, I've stopped listening. So I hate to sound a bit cruel, but as I said, there'll be stuff going onto my website tomorrow with how to put on and take off and clean the face shield. If you've missed any of that, I've got little snippets, little 4-minute snippets, and also the cleaning. But I do hope to have my protocol up tomorrow afternoon, because I just don't want anybody spending $6,500. See, that terminal clean, when you read about it, it is far more to do with the hospitals where people actually stay and cohorted, you know, like there's 2 or 3 or 4 cases. And that's really not us. So the other stuff I've seen at WorkSafe, it just doesn't talk to us in general practice. So hopefully I've helped. But I tell you what, if somebody gives me more than a page to read these days, I just don't have the capacity for it. So that's why I think things like webinars, and I attend webinar lectures, and it's just great, whether they're in America or here. There was a great one last week, Mary Lou McLaws and Greg Whiteley, fantastic. And Mary Lou's found out that we only actually do hand hygiene 25% of the time, which was devastating. So there you go. You've got to get stuck into your hand hygiene piece.
Mark,
Okay.
just before we wrap up, you were talking to me earlier about scenarios where practices didn't keep track of cleaners who had come and gone, and the difficulties when it came to tracing and the issues with those people that would come in and out of the practice moving around, and the responsibility that the practice has to track everybody who comes in, even the mailman dropping the mail on the desk. Is that going to happen?
Well, we don't have we've gone off things like wiping all your shopping. We've sort of, the evidence isn't so strong for that sort of stuff. And I know you probably heard, you know, that report yesterday about how long the virus can remain infective. I don't say the word live. Viruses really aren't alive, but they were able to show that they could reinfect cell culture. But we don't know how much virus we need. But it doesn't look like, I'll tell you where surfaces are a problem, and it's where your PPE, your gloves, have touched them. Then there's a heap of virus on there because you've touched somebody, you know, you've been caring for them, you touch a surface, and then somebody comes along with bare hands and goes like that. But we don't have loads of evidence, or even evidence, full stop, that there's really much coming off maybe a cough surface. We don't have really strong evidence about that. It's really that thing about being reasonably close to somebody, and I'm sorry, but I don't think 1.5 metres is far enough. It should have been at least 2 to 3. And we're now getting evidence of those small droplets, not the tiny aerosols, but the smaller droplets going at 4 or 5 metres. And so, you know, if you have no windows, no ventilation, in fact, worse, if you've got a blow heater or cooler blowing droplets over the patient's head to you, you know, as they're coughing, fantastic. Stuff will travel even further. So if you listen to the particle physicists, they say that anything that comes out of your mouth's an aerosol. As we microbiologists say, no, the aerosols are the tiny bits that stay suspended for an hour. And we're thinking of diseases more like measles. And measles has got an RO and a, you know, effective reproduction number of like about 17. Whereas this is around, COVID's around 2.2, but can be up to 4, like in the ships, you know, the Ruby Princess and all that sort of stuff. So we do know that we can infect more people in certain situations in COVID, and I think those enclosed spaces are where the RO is a bit higher. So, you know, ventilation, steer the patients outside, minimal time inside. Think about only having one person at reception and the person who takes phone calls in a phone room of their own. One of my clients, 2 receptionists, we were 1.5 metres apart, both got COVID. Mind you, I think the case of the drink bottle might have been a factor, but they thought that was okay. So I'm really a little bit thingy about 1.5 metres not being up. Inside, I really want just that one person on their own in the room. That's me, okay?
Okay, thank you, Margaret. Just to let everybody know, when Margaret finishes her videos that she's been making, updates on wearing mask, PPE, correct removal, and also the protocol for a deep clean, we'll be providing the link on our weekly newsletter to Marg's site, as well as having that on our coronavirus page for easy access, one-stop shop. Do we have any more questions? Otherwise, we will be having some final words from Brendan and our CEO, Dr. Moore. Can't see any more questions coming through. Okay, Brendan, thank you.
Well, thank you for that. Margaret, thank you very much on behalf of all of us. That was a fantastic presentation and answer to your questions. I'd like to introduce Dr. Michael Moore, who's the CEO of Central and Eastern Sydney Patch, and to provide a bit of a summary and some wrap-up comments. Over to you, Michael.
Thanks, Brendan. And Margaret, thank you very much for an entertaining and informative presentation. Certainly, you're speaking from a depth of experience, and you know, you've come out of Victoria where things have got a lot worse than things are in New South Wales. And I think one of the things that has come out for me, and I would say is the key point for me, is that COVID loves complacency. You know, relax and you'll get bitten. You know, and the points that I took out of your talk, Margaret, first of all, always act as if you're pre-symptomatic. I think that's a really good tip. So, you know, act as if the viral particles on your face, on your mouth, and how are you going to stop your patients from getting that? I think that's a really good tip because that also protects yourself as well. The other one too, you didn't actually say this, but and I might just check this one with you, but assume your patient is pre-symptomatic. So, you know, the person that comes in who hasn't told your staff that they've got a cough, don't be taken by surprise by that. Act as if anybody could do that. And so make sure you have things in place in your practice so that your staff and the other patients are still safe, even if that should happen. Try and avoid it from happening, but if it does happen, make sure that things are already in place so that they're safe. The other thing too is, and we didn't push this too hard during tonight, but I'd really like to push this, and that is always arrange a test for any patient with even the mildest of viral respiratory symptoms or any other symptoms consistent with COVID. When a patient comes in with a cough, don't say, oh, it's probably not COVID, go home and have some Panadol, you'll be fine. Don't say that. Now, this is Australia, it's 2020, there is a COVID pandemic happening. You're quite right, they probably don't have COVID, but how do you know if you don't test? The one that you don't test will be the one that has it. So every patient that has even the slightest symptoms, they've come to you, get them tested. The statistics that I can see nationally are that about 20% of patients that have respiratory infections that see their GP, to my surprise, do not get tested. Let's make that in our area 0%. Anyone that turns up to any one of your practices should be getting a test. We want to be picking up every single case. The other thing that I would just pick up too, and it was actually one of the questions was, you know, can we tell patients who are symptomatic not to come to the practice? Yes, you can. You can use telehealth for patients that are symptomatic but are otherwise well. If patients are symptomatic and they're unwell and they need to see a doctor, we're very lucky that we have GP respiratory clinics in our area. In the Canterbury local government area, we have respiratory clinics at Belmore and at Lakemba that you can use. So patients that need to be examined can be examined in safety by doctors that have got the full PPE on, everything. And that's a really good way to reduce risk in practice to keep patients that are symptomatic away. And then the last tip, and I thought this was a really good point that that Margaret made, was that, you know, don't forget, you've got to clean surfaces and equipment. And I have to say there's been 2 practices where the investigations come through, and there's a 3rd one now in Lakemba, where we had doctors infected. And everybody was doing everything right, and the one thing they slipped up on was keeping surfaces clean. And I think it's really important. And Margaret, I thought it was really good how you stressed how important that was, and you gave us the detail, the exact specific details of how you might do that. And I thought that was a really good part of your talk. How do I go?
Okay,
did I get it all right?
Yeah, pretty good. With a patient not declaring, I would just assume that the patients will not always declare for many reasons. And there was one other feature you mentioned. Oh, somebody mentioned about the home visits. Look, I didn't sort of buy in there. But perhaps you've got some thought there. Oh, I know what it was. The patient who's, oh, they're not too bad. Keep an eye on your positives. Call them every day. What has been happening is that even at the start, I'm not too bad, but they're actually hypoxic. And I mean, maybe they should come in and be tested or go to the respiratory clinic. So I would be very careful, like medically managing patients. Oh, they don't seem too bad. They're positive, but they're okay. You guys would be more expert. I'm not a doctor, but in terms of working out, oh, hang on, this patient's a little bit over the top. I wonder if they're a bit happy hypoxic or something like that. So that has been something that has caught a few clinicians unawares.
We're very lucky in our region in that Sydney Local Health District has got sufficient capacity and the cases are sufficiently low that anybody that tests positive, the lab automatically notifies the public health unit and they automatically get looked after by RPA virtual. And to date, there haven't been enough cases to saturate RPA virtual. I mean, it may well happen that RPA virtual will get saturated and we will have to return COVID patients to GP care. And we're currently negotiating what that might look like. And in fact, there are If you look at the Health Pathways websites, there's guidelines up already for how you would manage that. But certainly in the Sydney region, we're very lucky that at this stage, GPs haven't been exposed to that risk of looking after COVID patients at home. But if things get out of hand, it's a job we're going to have to take on.
Yeah, it was one of the regional PHNs who asked me, who said that they were doing that. So that was like a regional Victorian PHN. They really didn't have many cases, but they said they've put that into their pathways. I think that that they're saying keep an eye on that patient who's positive, that see them each day, you know, chat to them each day, that they, or their carer, that they are in fact getting better, but really the questions that you might ask that might reveal a hypoxia or something like that. Yeah.
I guess, yeah, the simplest advice I would give, the most memorable, easy to remember advice is if you do have a patient in the future that's COVID positive that's not being looked after by RPA Virtual or the equivalent over in South East Sydney, the advice is to go to the Health Pathways website because they've got very detailed instructions exactly along the lines of what Margaret's just outlined that you would use. So, you know, they're not new things.
Yeah, oh, that's good. That's good. Well, I sort of wanted to involve
clinic slip up on. I can't really comment on the Lakemba clinic because they're still doing the investigation, and it's not clear what happened there. One of the doctors got infected, and it's being investigated how that happened. With the other clinics where we had doctors infected in the region, everybody was wearing the masks, everybody was doing all the proper hand hygiene and so on, and it looks like the slip up was not keeping surfaces clean. But keeping surfaces clean is a trap for new players in the COVID. Like the obvious things like hand hygiene and wearing masks, people are onto, but the keeping surfaces clean, and I'm really glad, Margaret, that you emphasised that. It seems to be brilliant.
But also fresh air. You know, I think you're going to be getting about 3 air exchanges an hour, something like that. But windows, I mean, when we look at people, we don't know how they got it, but were they changing their masks every 2 hours, or was the mask getting wet? You know, all the question is are you wearing PPE? But that's not good enough.
Yeah,
it's not.
I don't know if the public health unit knows what happened, but it's not clear to us yet what happened in Lakemba.
I mean, I've got the chance to sort of, you know, drill down a bit, but I always say, well, even where we can't find it, where both of you are wearing a mask, it's not 100%. So PPE is not 100%. The air changes. You see, if that doctor is in that same room and that stuff is lingering, you know, for a few hours, then, you know, short of a P2 N95 mask, what are we going to do? But the air exchanges are going to help enormously. And yet some people are in shopping centres and can't do anything about that.
Yeah. All right, look, I think we're going to have to call things to a close now. There's been a question about do we have cleaning information, and there is cleaning information on our website, Dr. Marty. If people have got other questions, what I would suggest you do is get in touch with the practice support team, and Brendan gave me the email address for that. You're obviously all internet enabled people, because otherwise you wouldn't be on this this platform tonight, and good on you, everybody, for turning up tonight. If you do have any further questions, go back to our website, look for the practice support team, and their email address is practice support@csphn.com.au, and send them an email, and they'll there you go. We've got an answer up there already. practice.support@csphn.com.au, and they'll get back to you very quickly. They take their job very seriously of looking after the practices in the area, and they do what they can to help. Brendan, did you have anything else that you wanted to say before we call the evening to a close?
No, just thank everyone for attending, and thank you, Margaret, and thank you, Michael.
Thank you. Thanks for asking me.
We highly appreciate, Margaret, of you coming up at such short notice. We've had a bit of a scare with the hotspot in Lakemba, and we want to get on top of it fast, and that's why there's so many people here tonight, because we all want to do what's right.
Yeah, expect you might have about a third of the cases wrapped, but so do expect the numbers, you know, to maybe go up a bit. It just takes a while, you know, especially if it's been bubbling for a couple of weeks, which is what happens, and then kaboom. But eventually, look, just people honestly disclosing. This is where I went. I mean, you guys have got very few restrictions, so there'd be no reason why people would lie. But here, we didn't find out until 4 to 6 days later that this guy had actually gone further than what he'd initially said. And the virus didn't lie, it popped up.
Yeah, yeah.
Horrible, horrible.
Just the other thing before we close is that we've got a recording of this, and we will make that available.
And look, if there's one take-home message, the take-home message is this, and that is COVID loves complacency.
Yep.
All right, thanks everybody for attending, and thank you once again, Margaret, for an interesting and engaging presentation.
Thank you.